Good afternoon, everyone. Arboviruses are fascinating in their epidemiology and also in their disease spectrum. So I'm hoping that you guys will gain a lot from this talk. If your knowledge about arboviruses has been a bit like mine, a bit vague in the past, hopefully I'll shed a little bit of light today. So just to start off with some basics, what is an arbovirus? So an arbovirus is a virus that's transmitted by arthropod vectors. So in 1967, the WHO set up a group to define and study arboviruses, and they came up with this very kind of helpful definition. So arboviruses are viruses that are maintained in nature, principally or to an important extent through biological transmission between susceptible vertebrate hosts by hematophagous arthropods. They multiply and produce viremia in the vertebrates, multiply in the tissues of arthropods, and are passed on to new vertebrates by the bites of arthropods after a period of extrinsic incubation. So basically an arthropod is, an arbovirus is a virus transmitted by arthropods, and arthropods are any of a large group of animals with jointed limbs and a body made up of segments. So practically that means that an arbovirus is a virus that is transmitted to humans by mosquitoes, ticks, most commonly mosquitoes and ticks, but also midges and sandflies. If one looks at the WHO fact sheet on vector-borne diseases, which admittedly is not exhaustive by any means, a large proportion of these vector-borne diseases are vectored by arthropods and are viruses and would be classified as arboviruses. But arboviruses belong to multiple different virus families, namely the Bunyaviridae, Flaviviridae, Orthomyxoviridae, Reoviridae, Rhabdoviridae, and Togaviridae. There are over 600 different arboviruses, and 100 of them are known to infect humans. And the majority cluster within three groups, the Bunyaviridae, Flaviviridae, and Togaviridae. The Bunyaviridae have extensive genus and vector diversity, and they also have quite a different range in terms of severity of disease. The Flaviviridae are most probably the biggest and most relevant to us, and it contains one genus of arboviruses, all of which are transmitted by either mosquitoes or ticks. And the Togaviridae contains one genus, the alphaviruses, and are exclusively mosquito-borne, with both the Aedes and Culex mosquitoes serving as important vectors. But if we look at these groups in general, the flaviviruses are the most important in terms of the distribution and extent of disease, morbidity and mortality. So why are arboviruses important? Well, the first thing is the global burden of arboviral disease. Arboviral diseases account for about 70, or at least more than 17% of all infectious diseases and about 1 million deaths worldwide annually. The distribution of these diseases and the incidence of mosquito-borne arboviruses specifically are increasing. So this may include dengue, yellow fever, chikungunya, and Zika. And out of the arboviruses, dengue is the most prevalent and most relevant worldwide, with some estimates of about 220 million infections, other estimates up to 400 million infections and about 400,000 deaths annually. Also, the burden of arboviral disease is concentrated in tropical areas where half of the world's population live. And it is in these areas where the climatic conditions support the populations of the vectors, mostly mosquitoes, but other vectors as well, and support all year-round transmission of arboviruses. So globally, there is a massive burden of arboviral diseases. If we look at the main ones, dengue virus is present in tropical areas, both in the Americas, Africa, and Asia. Yellow fever virus predominantly in South America and Africa. Chikungunya also all over the world, as well as West Nile virus. Rift Valley is concentrated mostly within Africa and the Middle East, and then Crimean Congo Haemorrhagic Fever. And obviously Zika is not included here as well. If we take a quick trip around the world looking at arbovirus in different areas, in the USA, the most prominent arbovirus in terms of cases that are diagnosed and present to acute care units would be West Nile virus, but other viruses such as La Crosse Powasian, St. Louis encephalitis virus, Eastern equine and Jamestown Canyon virus are all arboviruses that have a significant amount of morbidity. If we look at Europe, chikungunya and dengue have over time presented in outbreaks all over Western Europe, but there are also other endemic viruses, such as tick-borne encephalitis virus. West Nile is present in Europe. Mosquito is a less known virus, but also endemic, and other viruses such as Syndbus and Crimean Congo Haemorrhagic Fever in some areas of Europe. And if we look at China, for example, Japanese encephalitis virus and dengue have a significant pose a significant threat, along with other less common arboviruses that may include chikungunya, Ross River, and other viruses that present in smaller amounts. But within Africa, if we look at the global distribution of major mosquito-borne arboviruses, including dengue, Zika, yellow fever, chikungunya, and Rift Valley fever, all countries that report transmission of all 5 of these are actually based in Africa. So Africa does bear a disproportionate burden of arboviral disease compared to other global regions. So it's important to summarize that arboviral diseases are important because of the massive global health burden that is possibly even greatest in Africa. The second important thing is the potential impact of global warming on arboviral diseases. So this is important to remember in a world that is dominated by climate change, how this may actually affect the distribution of arboviral diseases over time. And this graph shows the relative R0 of malarial diseases in Africa. This was in Kenya compared to dengue in terms of the mean temperature of the area. And as you can see, that if you look at the blue graph, as the temperature increases, so it favors the spread of dengue more so than malaria. What this ends up resulting in is, if you were to project over time with projected global warming over time, that for malaria, if you look at current high incidence and spread of areas, this area may actually get smaller over time at projections of the year 2050 and 2080. Whereas for arboviral diseases, because the temperature may increase from an average of about 25 to 27 degrees, the actual footprint and area in which arboviral diseases will be spread can increase. And some people have projected this may end up resulting in up to 50 to 80% more arboviral related deaths. Then the third thing is why arboviruses are important is the potential for pandemic spread. So we've seen this before with Zika virus. Zika, in 1947, scientists that were conducting routine surveillance for yellow fever in the Zika forest in Uganda isolated the virus in samples from a monkey. The next year, the virus was recovered from mosquitoes, also in the same forest. And then a few years later, the first human cases were detected in Uganda and Tanzania. So then between 1969 and 1983, the geographical distribution of Zika expanded to kind of equatorial Asia, also included Asia, India, Indonesia, Malaysia, and Pakistan. But in this case, there were only sporadic human cases and there were no major outbreaks. In 2007, Zika spread from Africa to Asia to cause the first large outbreak in humans. And this is on the Pacific island of Yap. This is in the Federated States of Micronesia. Then 2013 to 2014, there were other outbreaks in 4 other groups of Pacific islands. And then we all know what happened in 2015 and 2016, where Zika spread then to Brazil. When 2015, Brazil notified the WHO of this illness that was characterized by skin rash in its northeastern states. And then in 2016, it was declared a public health emergency of international concern. Similar for chikungunya, originally isolated in 1952-53 in Tanzania. Outbreaks were then identified in Asia thereafter. But in 2004, there was an outbreak in coastal Kenya that then spread to India, and where it caused an explosive epidemic and it spread around the world from there. In a similar way, dengue has over time increased in terms of the geographic spread and number of cases quite dramatically. Before 1970, there were only about 9 countries that had severe dengue epidemics, and now dengue is endemic in over 100 countries worldwide. So arbovirus has this unique potential to be to spread, and so this is one of the major reasons why they're such important viruses. So what clinical syndromes are associated with arboviral disease? This is an easy way to try and kind of break up the different arboviruses and to understand from a clinical perspective when you might be dealing with what may be an arboviral infection. So this is a Venn diagram that describes different kind of presentations or syndromic presentations. It divides it up to fever, arthralgia, and rash being one. Other approaches divide fever up onto its own, either with arthralgia and rash, or arthralgia and rash being on its own. But often they kind of come together. So either fever and rash, fever, arthralgia, and rash. That would be the one kind of common presentation, this would be the most common presentation of arboviral diseases, and diseases like chikungunya would fit into that syndrome. Viral hemorrhagic fever is obviously another syndrome associated with some arboviral diseases, and then other CNS-associated arboviral diseases in terms of encephalitis would be another. And there's obviously clearly overlap, as demonstrated in this Venn diagram, where some diseases will have fever, arthralgia, and rash, and a CNS presentation. Some may present with all three, and others may have hemorrhagic fever associated with fever, arthralgia, and rash. And so this is an easier way to try and break up the different diseases, although it can be confusing when they do overlap. So we just wanted to go through a few of the important arboviral diseases that are present outside of Southern Africa initially. And most of these diseases you may encounter as a clinician in South Africa in individuals that have traveled, either South Africans that have traveled over to an endemic area, or people resident in an endemic area coming to South Africa for work or other reasons. And so it's important to know the major arboviral diseases, as of course they are, as I said, close to 100. So just narrowing them down to the most important international ones. Dengue. So dengue is the most important arboviral disease. It's the most widely spread, accounts for the most morbidity worldwide, and is present in the Americas, also in Africa, and as well as in Asia and Oceania. Within Africa, if we look at this image, the dark red countries are those that have had dengue outbreaks within the last decade, and mostly along the east coast of Africa, but kind of dotted around. If we look at the countries that are pink here, these are countries that have had a dengue outbreak at any point in the past. So if you are seeing a patient that you may consider being a traveler that may present with symptoms of dengue, you'll need to consider travel to any of these areas: the Caribbean, Central and South America, Southeast Asia, Pacific Islands, and then obviously these parts of Africa, including our neighbors in Mozambique. It's a mosquito-borne viral disease, up to 400 million cases annually, and is transmitted by the female mosquito, mainly of the Aedes species, and Aedes aegypti mostly. It has rapidly spread to all WHO regions in recent years, as I showed in an earlier figure. And it's a flavivirus, which has got 4 distinct serotypes, dengue 1 to dengue 4. So the different serotypes used to be geographically spread. Pretty much you can get all different serotypes in all areas. You may have, if you get infected with one serotype, you will have lifelong immunity to that specific serotype. But interestingly, if you then get a subsequent infection with a different serotype, actually being infected previously with dengue increases the risk of severe dengue. And so this has also ramifications for the indication for the dengue vaccine, in terms of the dengue vaccine called Denvaxia, which is really only indicated for those who are seropositive or have had dengue in the past. It's important to note that currently there's an escalating outbreak in Nepal, amongst other areas worldwide. And dengue is frequently transported from one geographic area to another by infected travelers, and that's how it has kind of spread from certain areas to pretty much being present in many countries worldwide. The clinical features of dengue used to be described by the WHO in terms of 3 kind of different dengue flavors. So dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. And this is in a continuum of disease. In 2009, this was then changed mainly to try and highlight those individuals who may progress from one form to a more severe form. So there, the change was made to classify dengue as being dengue on its own with or without warning signs, and then severe dengue. So probable dengue would be someone who had traveled to an endemic area and then have fever with 2 of the following criteria. So nausea and vomiting, rash, aches and pains, having a tourniquet test, which is positive, leukopenia, or any of the kind of warning signs. And the warning signs would be abdominal pain, persistent vomiting, fluid accumulation, mucosal bleeds. And so importantly, progression to severe dengue is obviously what you're trying to watch out for, because those patients would require more intensive care, with the main issue being plasma leakage syndrome, severe bleeding, and then multi-organ involvement. Yellow fever is mostly present in South America and parts of Africa. Travel to tropical regions of sub-Saharan Africa and Central and South America would need to be highlighted. So if you have a patient present with features of yellow fever and has not been vaccinated, you may consider it as part of a differential. Or if someone has traveled from an endemic area, particularly in areas with low vaccine coverage, and you are then seeing them here. So it's an acute viral hemorrhagic mosquito-borne disease, can cause up to 200,000 cases of yellow fever annually and about 30,000 deaths. It's also caused by flavivirus, which is called the yellow fever virus, and there's one particular serotype, although there are subvariants. It's a disease that often occurs in epidemics, and there is a very effective vaccine available, and most people will be aware of it if you've ever needed to travel to or through a yellow fever area. Often infection is subclinical, and sometimes there may be some symptoms, but that the non-specific febrile illness may improve on its own without jaundice, and then you have the life-threatening disease with fever, jaundice, renal failure, and hemorrhage. Then the third important arboviral disease that's not present in South Africa specifically is Zika. And for Zika, you're worrying about travel to Central and South America specifically, and then Central and West Africa, and then the Pacific Islands that I mentioned earlier. It's caused by Zika virus, which is also a flavivirus, which is mosquito-borne as well, transmitted by Aedes species. And clinical symptoms are generally pretty mild. So they include fever, rash, conjunctivitis, muscle and joint pain, and normally lasts for 2 to 7 days. But it's not so much the primary illness that is as big a concern. It's more the complications, and particular complications we know are in pregnant women. One is for adverse pregnancy outcomes of the pregnancy itself, and the other is for congenital anomalies. And then there are also significant neurological complications of the disease itself. So it can lead to a Guillain-Barré neuropathy or a myelitis. So I wanted to move on to arboviral diseases in South Africa and focus on the most important ones, as well as a few others that are present, but not always, are not very common, but are just some important to keep at the back of your mind. So if we look again at the kind of Venn diagram I described earlier, and we look at the clinical syndromes associated with arboviral diseases, fever, arthralgia, and rash, encephalitis or hemorrhagic fever. For fever, arthralgia, and rash, chikungunya, Sinbis, and West Nile would be the ones that are most frequently associated with fever, arthralgia, and rash in South Africa and Southern Africa. Encephalitis may include West Nile, Rift Valley fever, and hemorrhagic fever, Crimean Congo and Rift Valley fever. So we'll go through these each in a bit of detail. So in terms of the syndrome of fever, arthralgia, and rash, chikungunya is not present in South Africa currently in terms of there's no active transmission of the disease, although it is suspected to be in sylvatic cycles. It is called chikungunya because it is the name is derived from the Swahili word, which means that which bends up, and that is associated with and that it's named like that because of the associated arthralgia that can be associated with it. So it's an alpha virus. It's in the Toga viridae, and it was first isolated in Tanzania in the 50s. It was first described in South Africa by James Geer in 1957. And in this case, this involved several patients that had visited the Kruger National Park in the autumn of 1956. And these patients presented with an illness that was characterized by sudden onset of joint pain, headache, muscular pain, and a macular erythematous rash. Also, these patients experienced prolonged episodes of painful stiffness that continued for several months after the acute illness. And initially it was thought to be dengue, but lab investigations at the time confirmed that it was likely chikungunya, or at least closely related to chikungunya. So it's transmitted mostly by the Aedes mosquitoes and maintained in nature in a sylvatic cycle that involves small mammals, mainly vervet monkeys and baboons in southern Africa. Intermittently, it can transmit into a human population, and within then form an urban cycle where it can be transmitted from human to human via mosquitoes and form small outbreaks of, or sometimes not small, but outbreaks of chikungunya disease. There have been multiple outbreaks in South Africa in the 70s, also outbreaks in southern Zim in the 60s and 70s as well. And in those cases, modern-day Mpumalanga and Limpopo provinces were especially affected, and it was thought to be the baboons and vervet monkeys that were maintaining that sylvatic cycle. Since then, there haven't been, there've only really been sporadic cases that have been confirmed in travelers, and there's been no recent evidence of the virus kind of circulating in South Africa. So if you want to understand the clinical features, it's useful to understand the pathophysiology of the disease. So chikungunya is transmitted by Aedes mosquito. The mosquito bites the skin, introducing the virus. The virus replicates in the fibroblasts of the dermis and then disseminates to tissues through the bloodstream. And then viral replication occurs in muscles, joints, and skin, as well as the liver, spleen, and meninges in neonates and those who are immune suppressed. Inflammatory cells are recruited to these particular tissues, which may involve the joints, and that's how you then get the joint pain associated with it. So generally, the incubation period is short, 2 to 6 days. Symptomatic period is normally about a week, although the polyarthralgia can last weeks to months and even years, and in some cases requires even the use of DMARD therapy, kind of treated in a similar way as you would to rheumatoid arthritis. The viremic period is pretty short, and the IgM is generally detectable round about within a week after the symptoms have presented. Synbis virus is an alpha virus, which was first isolated from mosquitoes in the Egyptian town called Synbis. This is back in 1952. And if you're going to get any arbovirus whilst you're sitting in Joburg or walking the dog in the park, then this is most likely to be the one that you may get. The virus circulates and is maintained in nature between birds and Culex mosquitoes with occasional human infection. It can be seen in the wetter parts of the South African Highveld, where the Culex mosquito breeds, and birds, in terms of especially water birds, serve as the host for the infection. In 1974, there was an extensive epidemic in the Northern Cape and the Karoo, and it was estimated to involve thousands of cases of both Synbis and West Nile virus infection. Synbis is present within Africa, Australia, Asia, as well as Europe. And if we look at this figure, there's been multiple different outbreaks in South Africa as well as in Northern Europe. And if we look at South Africa specifically, this study, which was done looking at seroprevalence of Synbis, found highest rates in the Northern Cape and the Free State. The clinical features are pretty non-specific. Initially, fever, headache, and sometimes arthralgia. The arthralgia typically involves the small joints and generally resolves. In Europe, the chronic arthralgia that has been likened to chikungunya has been described, although that hasn't been described in South Africa. The rash is quite distinctive. It appears on the body and the limbs, but is generally not seen on the face, and is described as a kind of fried egg appearance, where you may get the yolk in the middle and this kind of halo or pale area around it, and that's pretty pathognomonic of SINBIS, particularly if you can see it in pale-skinned people. There's been no evidence of encephalitis and no deaths associated with SINBIS, and generally laboratory confirmation is by means of the IgM and looking for seroconversion or increasing antibody titers with acute and convalescent serum measurements. The periods of viremia are shorter than for chikungunya and also less intense, but otherwise in terms of presentation can be quite similar, although the arthralgia is not as significant a component. Then if we move on to encephalitis, West Nile virus is present within Southern Africa, also present along in many areas of the world. It was first isolated from the blood of a febrile woman in the West Nile district of Uganda, and that's obviously where it got its name from. It's also a flavivirus transmitted by Aedes and the Culex mosquitoes, and actually the largest epidemic of West Nile virus ever recorded was recorded within the Karoo and the Northern Cape. I mentioned it previously, along with some SINBIS cases as well, and this involved tens of thousands of human cases. There was also another epidemic that was recorded in Gauteng, or modern-day Gauteng, in the 80s as well. There are multiple different lineages in Southern Africa. Well, South Africa, we've got lineage 1 and 2, and there are different clades within lineage 2. Despite evidence that the infection has occurred in a variety of livestock and wild vertebrates, the frequent isolation of the virus from wild birds has implicated them as likely the primary hosts of the virus. It's likely that humans and horses act as dead-end hosts and have low viremic levels and do not really play a significant role in the cycle of the virus in nature. But in veterinary circles, the importance of West Nile virus as a cause of disease in horses has been known, and this was described by some of our virology and infectious diseases colleagues in Pretoria. So as this figure demonstrates, normally human and horse disease is normally incidental. Due to the movement of migratory birds, the virus has also spread around the world, most markedly to the Americas in 1999, where it led to a significant outbreak of encephalitis in the New York area. And this was associated with significant amount of wild bird deaths. The birds that typically are infected with the virus in Southern Africa or in Africa generally do not get sick from the disease, but when the virus was transmitted to the Americas, the local bird population got particularly ill and died in their thousands. So much so that you could use bird deaths to predict when human cases were likely to happen. So in this figure, you could see that where bird deaths were reported early on in the year, you can see in this figure up on the right, the counties that were yellow and had reported bird deaths early on in the year were likely to report human cases later on, and would be then surrounded by this kind of little red block. So it was almost used as a proxy for anticipating encephalitis cases by monitoring the number of bird deaths. It's still a significant problem worldwide and a common cause of encephalitis in the US, with quite a few cases occurring annually. The clinical features of West Nile virus or West Nile fever, most people don't have any illness or symptoms. So 80% of people won't have any illness at all. Some may develop what's called West Nile fever, so some symptoms, which is generally fever and rash and myalgia. That's about 20% of cases. And then 1 in 150 will develop severe West Nile virus disease. And so this may manifest as meningitis or encephalitis or meningoencephalitis. And it's also an important cause of an acute flaccid paralysis or poliomyelitis-like flaccid paralysis. Diagnosis is made using a serum IgM. CSF generally, as you would have for any viral kind of meningoencephalitis, involves a lymphocytic clear-cytosis with a raised protein and a normal glucose. And CSF IgM is normally positive, with a PCR being positive less frequently. Neuroimaging as well can help. When present, MRI findings can include signal intensity abnormalities, maybe meningeal involvement, intraspinal abnormalities involving the spinal cord, chorda equina, and nerve root, and hyperintensity on T2 weighted MRI images that involve basal ganglia, the thalami, brainstem, and caudate nuclei. Then viral hemorrhagic fevers. So it's always important just to realize that if we're not just focusing on arboviral diseases, the viral hemorrhagic fevers with the important viral hemorrhagic fevers with person-to-person spread include, at least within Africa, Lassa, Ebola virus disease, Marburg, Crimean Congo Haemorrhagic Fever, and Rift Valley fever. And it's always important to consider the huge differential diagnosis when you may be presented with a case that may be a viral hemorrhagic fever. And this differential would include bacterial sepsis, typhoid, malaria, rickettsial disease commonly, and hepatitis, amongst other things. Remember that dengue, Rift Valley fever, yellow fever, and Crimean Congo are arboviruses. Lassa, Ebola, and Marburg are not arboviruses, and they're not vector-borne. So the important important viral hemorrhagic fevers that are present within South Africa would be Crimean Congo Haemorrhagic Fever and Rift Valley fever. Obviously, any can be transmitted via travelers. Crimean Congo Haemorrhagic Fever is the most widespread viral hemorrhagic fever globally, and it's a zoonotic virus of the Bunyaviridie family. It's tick-borne, transmitted by the Hyaloma species, and tick bites are the primary route of transmission to humans. So the nymphal and the larval ticks feed on birds and small animals, but the larger adult ticks feed on larger game and livestock. So one important thing to remember is that animals infected with the virus do not show signs of illness, and this is in contrast to Rift Valley fever. Most cases report close contact with animals, and so infection can be primary. So this forms a majority of infections, which is via tick bite or contact with ticks in terms of maybe crushing ticks in your fingers, or contact with blood or tissue from infected animals. And then secondary infections will be transmitted from other humans, so human-to-human transmission via exposure to blood or other body fluids. So then who is at risk? Well, for primary infections, it's anyone that handles or has contact with animals or ticks, so farmers, herders, abattoir workers, particularly people, game rangers and vets, people hunting, leather workers in the military, hikers, campers. And then for secondary infections, normally healthcare workers who are looking after patients with the disease, or lab personnel who are processing samples, or those that are handling the corpses of infected individuals. So CCHF in South Africa, the first case was reported in 1981. There have been further cases identified between then and now. There's an outbreak of about 8 cases in 84, which is called the Tygerberg outbreak. And in 1985, the NICD drew up their first kind of national guideline. Recently, a seroprevalence survey done by Mr. Mange et al. Showed that 74% of cattle sampled within the area of Northern Cape, Free State, and the Northwest, shown in the figure on the right, were seropositive for CCHF, with about 4% of the farm and wildlife workers being positive as well. And this is significantly higher than what's expected. Of all the laboratory confirmed cases between 1981 and 2019, most of them are from the Northwest, Northern Cape, Free State, and Western Cape. And this is mostly in warm, arid areas above an altitude of 800 meters. And this is where the high loma ticks like to live. Recently, this is from Outbreak News Today. This is at the beginning of this month. There's a report of the second CCHF case of 2022. And since then, there's been another case in the Western Cape, which would bring the number to 3, at least that I'm aware of, but there may be more so far this year. Generally, there's around about 10 cases a year or less, although there have been more in the past with outbreaks. So for the clinical features of CCHF, generally there's an incubation period of 3 to 7 days. Then that's followed by a symptomatic but pre-hemorrhagic period of about a week. During this period, individuals may have myalgia, fever, nausea and vomiting, and diarrhea. So these are obviously very non-specific symptoms. That's then followed by the hemorrhagic period of 2 to 3 days, where there may be bleeding from various sites, and also normally corresponds with the development of an IgM antibody response then, and then followed by convalescence. The hemorrhagic manifestations and organ failure normally start improving by day 10 or at that point get worse. But that's normally the time that patients kind of differentiate between kind of improving and worsening. There can be significant confusion and memory problems for quite some time after the illness. And infection likely confers lifelong immunity. In South Africa, over time, the mortality rate is about 1 in 4, so it's a really, really high. In terms of clinical diagnosis, Prof. Swanepoel and colleagues developed this criteria for CCHF in 1987, and it looks at symptoms or factors within 3 different areas or domains. So one would be a history of exposure to infection, and then there are points allocated to each of the characteristics, and a total score of 12 points or more constitutes an indication for treating a patient as a case of CCHF. So an important history would be having been bitten by a tick or crushed ticks with the bare hands. And because of the short incubation period, more points are given for the time being within a week of that happening and presenting. Direct contact with fresh blood, or contact with blood secretions or excretions of a confirmed case. Other signs and symptoms would be sudden onset, fever, headache, myalgia, but most points are given for bleeding tendency. So 3 points would be given for that. And then in terms of the lab characteristics, leukopenia would be important, low platelets below 100 particularly, as well as an abnormal clotting and raised transaminases. But if we're looking at this is just for clinical diagnosis, if we're looking at a lab diagnosis, molecular tests using a PCR is particularly useful during the first week, and would be positive from early on in disease, and would generally remain positive for up to 7 to 10 days. It gives you a quick result, generally a quick turnaround, but can only really be done at the NICD, and would require transport there. There are very clear guidelines as to how samples should be translated safely for viral hemorrhagic fever workup. Serology becomes positive normally by the end of the first week, and may remain positive for quite a while. The development of a positive response, antibody response, is often thought to be an indication of a good response and good potential outcome, because patients that fail to develop a response generally have a poor outcome. Rift Valley fever, present in large parts of Africa and into the Middle East, is a member of the Bunya viridae as well. It was first identified in the 1930s amongst sheep on a farm in the Rift Valley of Kenya, and that's where it gets its name from. Cattle, sheep, and goats serve as the natural hosts, and the vectors are Culex and Aedes mosquitoes. In contrast to CCHF, outbreaks in livestock cause disease, and these are characterized by abortion storms and high mortality in young animals. So animals generally get, or the younger animals get sick, as opposed to CCHF when they would be asymptomatic. Humans generally become infected with contact with infectious products, such as the blood and meat of carcasses, but they can, although less commonly, be transmitted by the bites of mosquitoes. There have been multiple previous epidemics in the 50s, 70s, and most recently, just before the 2010 World Cup. I don't know if anyone remembers that there was a kind of global outcry with this outbreak of viral hemorrhagic fever just before the 2010 Soccer World Cup started and was splashed across the news internationally. During this outbreak, there were cases reported in a wide area of the Eastern Cape, Western Cape, Northern Cape, Northwest, and the Free State. There were outbreaks, or the disease was picked up in multiple different animal species, including domestic animals, as well as springbok, waterbuck buffalo, even foreign animals like llama, alpaca, Asian buffalo. The human cases mirrored the distribution of animal disease quite predictably. Most human infections are mild, and severe complications and death occur in only a small proportion of those affected, so less than kind of 1%, and treatment is generally supportive. So mild disease would be headache, retroorbital pain, neck pain, myalgia, with severe disease, possibly including an encephalitis, ocular disease as well, with multi-organ involvement involving hepatitis, jaundice, and acute kidney injury with bleeding. So the disease can generally be broken up into Rift Valley fever without complications, or with eye complications, with meningoencephalitis or with bleeding. There are some other lesser known arboviruses, and these are important to know because they have the potential for outbreak in South Africa, although they don't cause significant burden of disease that we are aware of. So one would be Wesselsbron, which was named after the town Wesselsbron, was isolated from infected sheep there. It's similar to yellow fever, although it doesn't cause a severe disease as yellow fever. There was one South African case of laboratory infection of someone who was working with it. And there have been other human cases in Senegal and Central African Republic. But if we look at serological studies, there's quite significant evidence of seropositivity in South African provinces of the Free State and KZN. Middleburg virus has not yet been linked to human disease, but has been detected in horses and birds in South Africa, Zim, and also Senegal, and has the potential to cause human disease. Spondweni has been isolated in KZN before from mosquitoes. It has been associated with human disease in expats living in West Africa, and the symptoms are very similar to fever, arthralgia, and rash that has been shown before. Lesotho virus was been isolated as early as 1959 in KZN from mosquitoes. It's similar to Japanese encephalitis virus. It's present in Europe as well. We haven't had any human cases, but there was a report of 2 immunocompromised cases that developed encephalitis due to the virus in Italy. So it has a potential to cause human disease for sure. And then Banzi virus, which has been described before in a 9-year-old boy that was living near the Maputo River. It's also caused disease in Tanzania. And there have been limited but proven human cases. But also serology has shown that it is around. The serology has shown that it does circulate in South Africa, Mozambique, Angola, Namibia, and Botswana, and so could potentially be a virus that may cause future disease. So if there are so many different arboviruses and they're so extensively distributed, why do we not see more of it? And as clinicians, this is a question that we may ask ourselves. And some of it may just be because we never think of it. Patients, particularly presenting with fever, arthralgia, and rash, often get better on their own. They won't present to a hospital. They may present to their GP or the clinic. And so it may be ascribed to an allergic reaction or to a drug reaction or to something else. And we may just not see it as often. So maybe we are missing cases of Sinbis, West Nile, Chikungunya, or any of these other cases that other viruses that may be present. I think hemorrhagic fever as a syndrome, we're less likely to miss, but as the differential is very wide, and often you may be ascribing hemorrhagic fever due to arbovirus to something else, because the differential is so wide. But a particular area that we may, I think, be missing cases maybe in those of undiagnosed or encephalitis, or patients where we don't actually ever work out the cause. And so this is highlighted by a lovely study that was done by guys at the University of Pretoria, where they looked at West Nile virus in humans back in 2008 and 2009. So what they did was they looked at lab submission requests for patients who presented with symptoms that could have been consistent with West Nile virus and had no other proven cause of their presentation. So they present with fever, headache, rash, or neurological signs. They had 206 patients, 15 CSF and 119 serum samples, and they then screened them for the presence of West Nile virus using RT-PCR neutralization assays and an IgM ELISA. And what they found was that up to 15% of them had West Nile virus neutralizing antibodies. And if they looked at them, about 7 of them had probably had acute West Nile virus. So it's not an insignificant number. And this indicated that we may be overlooking it as a cause of severe disease in South Africa. So if you look at the 7 cases that were acutely ill and thought to likely have had West Nile, some of them presented with neurological symptoms, others with fever and disseminated disease. But all could have been someone that we have seen and ascribed to some other cause. Particularly, we get these patients who come in with confusion, look like an encephalitis, put on acyclovir. You do your viral multiplex, which comes back as negative, and the patient generally gets better. You think it must have been something that wasn't tested for, or the patient naturally just got better anyway, and move on. So we may be missing some of these cases. Finally, we want to move on to diagnosis. With most of the arboviruses, they have a very short period of viremia, at least after symptom onset. And so when we're looking at the diagnostic options being virus isolation and molecular methods such as PCR, the window for detecting a positive PCR in most of the arboviruses is very, very small. And so often a negative PCR may be seen because the viremia has subsided by the time the sample is taken. IgM comes up quite early, normally within a week of infection, but is not always reliable because of significant cross-reactivity, particularly for the flaviviruses. And so it's important to always do convalescence serology. So do it baseline and then repeat it after 2 weeks following the acute phase of infection to see if there's been a rise in titer or seroconversion. You always need to remember that there are issues with serology. So there's cross-reactivity, not just to other viruses, but to previous vaccination. So if someone had been vaccinated for yellow fever, for example, if they traveled from Asia and been vaccinated for Japanese encephalitis or Europe tick-borne encephalitis, or previously received Denvaxia for dengue, these can all interfere. You want to do IgM and IgG and also check for an increase in titer. But also there's variability in the sensitivity and specificity of the assays. It's also important to mention when and give the lab details as to the symptoms associated. So this is a suspected arbovirus case investigation form with some details if you wanted some advice from the NICD. Details what viruses you worried about, patient details, patients' syndromes, where they traveled to, and the pathological findings. And so filling this out as detailed as possible before sending samples really helps to try and nail down what tests should be done, and then to interpret the results and come up with a reasonable diagnosis. So in terms of the tests that are done at the NICD, amongst others, the ones that are routinely done for, say, viral hemorrhagic fever would be Ebola, Marburg, Crimean Congo Haemorrhagic Fever, and Lassa. and Rift Valley fever could fall into that if there are some symptoms of a viral hemorrhagic fever, but otherwise, in terms of arboviral disease, Rift Valley fever, Sinbis, Chikungunya, West Nile, and dengue. I had a chat to Prof. Lucille Bloomberg just to ask her what she was unfortunately unable to join the talk, but she's always got a lot of advice and a few kind of pearls of wisdom, and so I asked her what she would give in terms of pearls of wisdom with respect to arbovirus viral disease. And so she mentioned these things. So number one, so think of arboviral disease when you present it with someone with a fever, myalgia, and rash, plus or minus arthralgia, or in someone with non-specific symptoms and low platelets and lymphopenia. If you are thinking about arboviral disease, consider the geography, know which diseases are located where, be aware of what seasonal outbreaks are happening at the time, and consider the incubation period. So generally, the incubation period is within 2 weeks at the most for most arboviral diseases. So if the patient traveled to an endemic area beyond this, it's very unlikely that they have an arboviral disease. And remember, dengue is, she said, one of the ones that are missed most frequently. Always request the correct lab test, get hold of the NICD and speak to the team there. Orienka is on the call, I think, and we'll ask her for some of her comments now. But if you ever need any advice, give the NICD a call and discuss exactly what you're looking at, and they are very, very helpful. Remember, PCR in the first week is useful, thereafter serology, and if you're doing serology, do acute and convalescent serology and provide all the information that is required. And then remember the cross-reactivity of serological tests. So at that point, I'll wrap up and see if there are any questions. And also maybe we'll ask Orienka if she has any advice or any comments on arboviral disease, because she's dealing with it frequently and has huge amounts of experience.
Yeah, thanks, Lyle. Maybe let's turn over to Orienka at the moment, because I know the load shedding is imminent for her.
Okay, thank you, Lyle, for the great presentation on arboviruses. I just have a comment and a question. So we saw about a 70% decrease in samples being submitted to us at the NICD since the beginning of COVID, which was 2020. So I'm just wondering, is it because the patients don't present to the healthcare facilities, or could it be that the clinicians and GP maybe don't think of arboviruses?
Sure, yeah, I mean, I think that's interesting. I mean, I think obviously there's a decrease in travel associated with COVID that was quite significant, but I think COVID took over everyone's brains for quite a significant period of time. And I would think that it's a combination of the two, but I doubt that the arboviral diseases are going away. It's most likely that we're just really not thinking about it. And maybe it was something at the front of our minds, and now we're really just getting our minds back to pre-COVID thinking.
Okay, thanks so much. Yeah, so this is maybe a good reminder for people to think about arboviruses, and like you and Prof. Bloomberg said, it's really important to give us the CIF so that we have all of the information, so that we can paint the picture and all of the pieces of the puzzle when we do the interpretation. Also because we have this cross-reactivity with the different flavivirus. But that's all from my side. Thanks.
Yeah, thanks. It's really helpful. I see Dr. Land is asking, are there any South African cases of transfusion-related arbovirus transmissions?
Yeah, look, I mean, I'm not aware of specific ones that come to mind or that I've seen in any literature of late. Orienka, I'm not sure if you guys have been aware of any. I mean, it's definitely the potential, but
yeah, I know they say it's a potential with the flaviviruses, but also not something I can think of now.
I guess they're quite, they're not viremic for long, many of them. I mean, it depends on which one you're talking about. And, they're probably quite sick at the time. So Well, I guess not always, right? I mean, some of them may be asymptomatic. So yeah, interesting. And then I see Michelle Naidu said, okay, so they talk about the changing classification of Crimean Congo Haemorrhagic Fever and Rift Valley Fever, which is something microbiologists do to us poor physicians routinely just to preserve their expertise. Really change how everything is classified all over again. But the point well taken. And then Evan saying, could someone from the labs talk to us through diagnostic options for CSF testing? So could you screen with serum serology, or would you, what would you do? PCR first, or what would you do?
I can maybe quickly answer. So for the, if you suspect encephalitis, we can do serology and PCR on both CIF and serum samples. So we've had cases where clinicians submit both samples. Obviously, the viremia is very short, so sometimes we miss it, but we can do the IgM as well on the CSF.
Sure. And then, you mentioned convalescent samples. So, obviously the idea you're sending blood again, maybe 1 to 2 weeks later. Does that apply to CSF too? I mean, should you send 2 CSF samples, or is that not necessary?
That's a very interesting question. I think it would be nice if you can send, we talk about the convalescent sera, but I don't know, I haven't read about the CSFs. It would be interesting to see.
Yeah, that's, we've had a few cases where we've sent off at least for West Nile testing, but not proven at least for any of our cases with encephalitis. But I agree with you. I mean, I think that's one important syndrome actually too. If the other ones, if you miss it, it's not the end of the world, especially if it's a sort of mild arthralgia rash that disappears. That may not have clinical implications, although it's obviously diagnostically interesting and may stop you looking for other things. But encephalitis in particular, is something which we really do need to keep pushing to diagnose more and more cases, to find a definitive diagnosis for many of them. Many of them you don't.
I think especially if if you took the effort of getting the CIF, you might as well just test it.
Yes, yeah. And then for these cases, I mean, I don't know for some of these, let's say West Nile, let's specifically say, I mean, how common is a lymphocytic CSF in that? Is it reliable enough to use it as almost like a screening test, or can you have cases even with a normal looking CSF?
I'm not sure. I can look into that for you, but I think most of the time, there is a picture on the CIF that guides you towards the encephalitis. So
yeah. And then there's a comment about saying cross-reactivity is not such a big issue with most of the current serological tests. But a lot of the IgGs are qualitative, not quantitative, so difficult to see rising titers. I don't know, that's presumably from Lancet's side. Is your experience similar, or do you do a different assay?
So with the commercial IgMs that we do specifically for dengue and West Nile, we see some cross-reactivity, not so much with Zika, but we definitely see, even Usutu, we recently did a study, and we're seeing these high numbers, but we have to do viral neutralization studies. We can't tease them out and be sure that it's specifically dengue or West Nile.
Okay, no, that's handy, yeah.